Hi everybody. Today's topic is we'll be discussing December 2021 paper 1 DNB questions. The first question is, what are various manifestations of intracranial tuberculosis? For this they have given 2 marks, and later second part of the question is discuss the clinical presentation, pathology, CT and MR findings of any 2 of the manifestations. For this they gave 8 marks. 8 marks means we have 2 points here, 2, 2, 2. So they have divided 4 questions in a single one. So for each one it is 2 points and total is 8. Total score for this is 10 marks. So let's go into the discussion. Coming to the first part, what are the various manifestations of the intracranial tuberculosis? So what are the manifestations of intracranial tuberculosis? And just write in the examination, just write whatever they ask so that you can manage the time properly. So what are the manifestations? We have TB, meningitis, tubercloma and pseudoabscess. Only 3 points, remember. So TB, it causes meningitis. It may form tuberclomas and it may cause abscess. They are pseudoabscess. I'll tell you why they are called as pseudoabscess. So only 3 manifestations. It's TB meningitis where we get exudates. We have tuberclomas and pseudoabscess. So we have first question we have completed. We get two points for that. And next is clinical manifestations. Clinical manifestations, we have fever, headache, meningismus, signs of increased intracranial pressure, confusion, lethargy, seizures, coma, and cranial nerves are involved mainly. 3rd cranial nerve, 4th, 6th and 7th cranial nerves are involved. We have completed this question. Then going to pathology. Coming to pathology, before going to pathology, we should know some basic points. Intracranial tuberculosis. So first there will be an extracranial infection. Most common site of extracranial infection is lungs. Through lungs, through the blood, the infection goes into the CNS. What happens when it enters the brain? In the brain, first it forms a small TB-rich foci where in the subpial and subependymal surfaces of the brain and spinal cord. What is this subpial? So we have, this is above we'll have scalp, then we have dura mater, arachnoid matter and pia mater. So this is arachnoid matter, this is pia mater. The space between the arachnoid matter and pia mater is the subarachnoid space. And we have brain, the subpial, this is the subpial space. Below the pia mater, this is the subpial space. This is the vessel. When you take a cut section here, this is the vessel. Around the vessel we have perivascular space. Around the vessel we have perivascular space. Then we have subpial space and then we have brain parenchyma. So what happens? So this in CNS, when the infection enters the CNS, there will be a small TB-rich foci within the subplial or subependymal surface of the brain and spinal cord. From there will be rupture of this TB-rich focus into subarachnoid space. There will be rupture of this focus into the subarachnoid space. Then it may cause meningitis, vasculitis or encephalitis. Pathology. Coming to the next part, they have asked about pathology of neurotuberculosis. We have 3 manifestations. They have asked about only 2 manifestations. I will be discussing about 3 manifestations. One is meningitis, other is granuloma, that is tubercloma and TB abscess. So first coming to meningitis. TB meningitis, here meningitis. So it's an inflammation of the meninges. So what happens? There will be it's an inflammatory reaction. So exudate. So what happens in TB meningitis? They'll have exudates. Exudates occur in the subarachnoid cisterns. So subarachnoid space we have cistern, the subarachnoid cistern. So these are like exudative, proliferative and necrotizing components. These components. What happens? The most common sites of the subarachnoid cisterns is basal cisterns, the most common location. So they may also occur in the superficial convexity of the brain. In the sulci also the exudates go and sit. But most common space is the basal cisterns. To the pathology, they are like dense, diffuse, glutinous exudates that accumulate in the basal cisterns, coating the brain surfaces and cranial nerves. So we have supracellular chiasmatic region, ambient cisterns and interparenchymal fossa. These are the most common basal cisterns which are involved. This inflammatory exudates, what they do, they encase the major vessels and their perforating branches and invading vessel walls. So these exudates, they go and surround the vessels, their perforating branches and also vessel walls. What happens due to this? They'll have true pan-arthritis, that is endarthritis obliterans will be present, and this leads to vessel occlusion with secondary infarcts. So most common location for that is basal ganglia and internal capsule. So exudates, most common pathology have involved, they are like exudative, proliferative and necrotizing component. Basal systems are most commonly involved, even the brain surface is involved. Then what happens? They involve the vessels. Due to involvement of the vessels, there will be panarthritis. So vessel get occluded. Due to occlusion of the vessel, there will be infarcts. Most common location is basal ganglia and internal capsule. When you get a case of TB meningitis, look for exudates mostly in the basal systems. Then go and see the vessels. And also whether they are narrowed. Then look for infarcts. Then coming to TB granuloma or tuberclomas. They are focal parenchymal infection with central caseating necrosis. They are space occupying masses of granulomatous tissue. So which are the sites involved? Are cerebral hemispheres. There is a frontal and parietal lobes are most commonly involved. In basal ganglia they can be focal, dural, intraventricular, that is choroid plexus, or isolated calvarial lesion. They can also present like this. But most common is cerebral hemisphere, the frontal and parietal lobe. Normally, majority of them are small. There is less than 2.5 centimeters. It can be miliary also, like few millimeters in diameter. They can be giant, like 4 to 6 centimeters. The most common is small, that less than 2.5 centimeters. They can be solitary or innumerate small miliary regions. So like creamy cheese-like necrotic center surrounded by grayish granulomatous rim. So coming to this, we have a central caseating necrosis surrounded by we have a capsule which contains fibroblast, multinucleated giant cells, epithelioid histocytes, plasma cells and lymphocytes. So this is about TB granuloma. Coming to TB abscess. TB abscess, it contains macrophages and liquefied necrotic debris. Within the abscess, we have macrophages and liquefied necrotic debris. Why it's called a pseudo abscess? Because there is no pus with neutrophils in this. They have macrophages, and so it's called a pseudo abscess. They're found anywhere in the brain, from the hemisphere to the midbrain to the cerebellum. So TB abscess, it consists of vascular granulation tissue with acid-fast bacilli, liquefied necrotic debris and macrophages. So this is about pathology of neurotuberculosis. Then coming to the next question, imaging findings. Imaging findings of neurotuberculosis. So normally what we have to remember is, in early stages of TB meningitis, when you do CT scan, it appears normal. So in early stages, contrast enhanced MRI is the imaging of choice, remember. Then coming to first is CT findings. Coming to CT findings of TB meningitis. So we'll be, they have asked for 2 manifestations, but I'll be discussing about all 3 manifestations. The first is TB meningitis. So if you get a cut section, first we have a normal plain CT. What are the findings? And on contrast CT, what are the findings? On plain CT, what happens when you just scroll along the CT images? There will be non-specific hydrocephalus. There will be non-specific hydrocephalus. And when you see the margins of the ventricles, there will be blurred. There will be blurred ventricular margins. Why there will be blurred? This is due to extracellular fluid accumulation in the subependymal white matter. So NECT, what happens when you scroll to the sections, you will see non-specific hydrocephalus. When you see the margin, there will be blurred. This is mainly due to extracellular fluid accumulation within the subependymal white matter. Then as the disease progresses, we will see exudates. The most important is exudates. On non-contrast CT, how are these exudates? So we know that most common site for exudates is basal cisterns. And they also They will also be present along the sulci, even the sulci also. So most common basal systems. So exudates on non-contrast CT, they appear as iso to mildly hyperdense. So they are hyperdense. They can be iso-dense or hyperdense. They are iso to mildly hyperdense basilar sulcal exudates. So what happens? They replace and efface the normal hypodense CSF. Then coming to CECT. CECT, what happens? These exudates, they enhance. Thick enhancing exudates throughout the basal systems. This basilar meninges and subarachnoid spaces. The basal systems, they are like basilar meninges and subarachnoid spaces are involved, and where we can see thick enhancing exudate throughout the basal systems. So one thing we have to remember in TB meningitis, on non-contrast CT, first there will be non-specific hydrocephalus with blurred ventricular margins. Then as the disease progresses, we have exudates which are iso to mildly hyperdense, and they replace and efface the hypodense CSF. And when you give contrast, they enhance. Okay. Coming to MR findings. What are the MR findings? On MRI, how TB meningitis looks. So coming to basal exudates, we have T1 weighted imaging. Basal exudates, T1 weighted. On T1 weighted, they are iso intense with the brain. How is the brain? They also appear like that only, iso intense. That's why it gives an appearance of dirty CSF. Then most important sequence we have to take is flare. On flare, they appear as increased signal intensity in the sulci and cisterns. Any case of TB meningitis, one of the important sequence, flare. On flare is one of the important sequence. So on T1, we have, it appears like a dirty CSF. It will be iso intense to brain. On flare, there will be increased signal intensity in the sulci and cisterns. Then once you give the contrast, T1 contrast with fat suppression, what happens? There will be linear nodular meningeal enhancement. How is enhancement? Linear and nodular. Then coming to, so these exudates, they extend into the brain parenchyma along what? Perivascular spaces. I told you, right? Subarachnoid space, pia mater, subial space. Around we have a vessel which penetrates. Around the vessel we have perivascular spaces. So what they told? Exudates, they extend into the brain parenchyma along perivascular spaces. In the subarachnoid space, we have subarachnoid cisterns. Along the perivascular spaces, they spread into the brain parenchyma. So when they spread into the brain parenchyma, we get meningoencephalitis. Complications. Next is vascular complications. Exudates, they involve the vessels leading to panarteritis, endarteritis obliterans. There will be vascular occlusion and infarcts. So vascular complications, look for phlovoids of the major arteries. It may be irregular or reduced. So any case of TB meningitis, look for exudates, vessels, any brain parenchyma is involved. In the vessels, you have to look for if they are irregular or reduced. That is, look for the phlovoids, how the phlovoid is. Then coming to penetrating artery infarcts. Normally there will be acute, hyperacute, and in this normally we see restricted diffusion and enhancements are common in penetrating artery infarcts. Then cranial nerve involvement. Most common affected are second, third, fourth and seventh cranial nerves are most commonly affected. How they look? They'll be thickened, they enhance intensely on post-contrast imaging. Thicken, enhance intensely. This is about TB meningitis. Coming to next manifestation, tuberclomas. Tuberclomas, how they present on NEC. Plain CT, how they appear? They appear iso to slightly hyperdense. They appear iso to slightly hyperdense. A tubercloma can be round, lobulated or crenated. There can be any shape. So there will be perilesional edema. Plain CT, we will see something like isodense or hyperdense lesion with surrounding edema. If there is in healed granuloma, there will be calcification. In contrast, these are non-contrast CTs. On contrast enhanced CT, they have three types of enhancement. They'll have ring-like enhancement, they'll have solid enhancement or punctate enhancement. So normally on non-contrast CT, that is plain CT, There's iso to slightly hyperdense. They can be round, lobulated or crenated. On contrast enhanced CT, they can have solid enhancement, punctate enhancement or ring-like enhancement. Then coming to MR findings of tubercloma. TB granulomas are solid caseating necrotizing lesions. So on T1 weighted, how they appear. On T1 weighted, tuberclomas are hypo or iso-intense with the brain. They are similar to brain or little less. On T2 weighted, on T1 weighted, they are hypo or iso-intense with the brain. On T2 weighted, they are hypo-intense foci surrounded by edema. If there is a liquefied area, T2 hyperintense with a hypo-intense rim. Remember, T1 hypo or iso-intense with the brain, T2 is also hypo-intense foci. Unless there is liquefied area. Liquefied area, it appears T2, hyperintense. So contrast, you give a contrast with fat suppression, enhancement will be seen. Enhancement will be like small punctate foci with small punctate foci to multiple rim enhancing lesions. It can be a punctate foci or multiple ring enhancing lesions on contrast. So on contrast, next we have like mild to moderate round or lobulated ring-like enhancement. So enhancement can be small punctate foci, multiple ring enhancing lesions or mild to moderate round or lobulated ring-like enhancement around a non-enhancing center. Then on perfusion imaging, how it appears? There will be elevated relative cerebral blood volume in the cellular and hypervascular enhancing rim. When you put focus on the enhancing rim, where there is a cellular hypervascular region, there we have elevated relative cerebral blood volume. Then coming to diffusion weighted imaging. Diffusion weighted imaging, as they are solid caseating granulomas, they do not restrict on DWI unless there is a liquefied foci that may restrict. So normally there no restriction is present. On spectroscopy, spectroscopy is most important. Spectroscopy, it helps in distinguishing these tuberclomas from neoplasms or pyogenic abscess. So in TB granuloma, that is tubercloma, NAA is to creatinine ratio will decrease. There will be very prominent decrease. NAA is to choline will be moderate decrease. Lipid lactate peak will be present with absence of other metabolites such as amino acid or succinate. Most important, lipid lactate peak, prominent decrease in the NAA and creatinine. NAA is to creatinine. Then coming, this is the manifestations of tubercloma. Then coming to abscess. These are pseudo abscess because they do not have any pus, neutrophils or pus. They have mainly macrophages. On NECT, this abscess or hypodense. They have significant mass effect with surrounding edema. On contrast, they have ring-like enhancement. Okay. Then cerebritis is very rare. Normally on MRI, these TB abscesses are uncommon. Normally these TB abscesses are uncommon. They can be solitary or multiple. Multiloculated, that will be more than 3 centimeters. They resemble a neoplasm because they got significant mass effect and with surrounding edema. Suddenly if you say you feel like some neoplasm is present. One of the disease is neoplasm. They are multiloculated more than 3 centimeters. Okay. On T2 weighted and flayed, they are hyperintense to brain. On diffusion weighted, restriction will be present. On T1 contrast, ring enhancing, multiloculated lesion or multiple separate lesions. On MRS, there will be lipid lactate peak without evidence of cytosolic amino acids. This is about TB abscess. Coming to differential diagnosis. They didn't ask of differential diagnosis in the question. Differential diagnosis. For TB meningitis, one of the differential diagnoses is pyogenic meningitis, carcinomatous meningitis. This carcinomatous meningitis are mostly seen in older patients. They have an history of systemic or primary CNS neoplasm. Neurosarcoidosis is also one of the DD for TB meningitis. Here there will be infiltration of pituitary gland, infundibulum, hypothalamus is common. Coming to tuberclomas, multiple tuberclomas, one of the most common DD is NCC. In neurocystic sarcosis, there will be different stages of evolution. And this is one more question I'll be discussing in the other video. How do you differentiate tuberclomas from neurocystic sarcosis? So another DD for tuberclomas is pyogenic abscess. Normally these tuberclomas are solid caseating lesions and they do not restrict on diffusion weighted imaging. These pyogenic abscess, they restrict on DWI. Neoplasm, they'll have elevated choline levels. Tuberclomas, they lack elevated choline. Lipid lactate peak will be there. Coming to TB abscesses, one of the DD is pyogenic abscess. Diffusion restriction will be there. Here also diffusion restriction will be there. Here on spectroscopy there will be cytosolic amino acids. On spectroscopy there will not be any cytosolic amino acids. Only lipid lactate peak will be there. Thank you.